Anji, hello. I hope I'm audible and visible to all of you. So let's start with the discussion of most important questions. There are some 20 questions from neurology as well as endocrine. Let's begin. Okay. Very good evening to all of you. Right. So let's see the first question in the question bank that we've got. A 45-year-old male patient is brought to the emergency department in a convulsive status epilepticus for the last 12 minutes. IV access is not yet available. What is the next best step for the management? What are we going to do next? Wait for the IV access? Should I wait for the IV access and administer lorazepam? Or should I administer intramuscular midazolam? Should I administer rectal diazepam? Or should I start with a phenytoin oral through the nasogastric tube, because oral is available with us? Yeah, obviously we know the protocol very well, that whenever a patient comes to us in status, the drug of choice is always a benzodiazepine, that you know. Yes. In a patient with SC, that is status epilepticus, the drug of choice is always a benzodiazepine analog. In the group of the benzodiazepine analog, the preference is always given to which one? Yes, the lorazepam. The preference is always given to the lorazepam as compared to the next congener in the list that we know is a midazolam. Now, if I want to give my patient lorazepam, ideally it should be given through the intravenous route. While midazolam has an added advantage, it can be given through the intravenous as well as intramuscular route. Like in this case, clearly being specified, the IV access is not yet available in our case. Yes, so we'll like to give our patient this very drug in a phase that we know as a, so we are going to give our patient this drug in a intramuscular form. Now, what's your opinion about the rectal diazepam? Any idea? Because there's a lot of confusion happening on this also. Because in pediatrics, they give rectal. Now, in a trial being done, it's been clearly stated that the intramuscular midazolam will always hold better results than your rectal diazepam. Okay. In bachas, in children, yeah, I can give, but in adults, just imagine a patient having seizure and you giving it intrarectal. So just imagine this, what would be the scene over there, right? Okay, good. So we are thorough with the status epilepticus. Another part, don't forget the definition. In a convulsive form, whenever the seizure is lasting for a duration of more than equal to 5 minutes, that is known as status epilepticus, right? Okay. And yeah, okay. So just a quick recap, the anti-epileptic drug for status epilepticus should ideally be the drug of choice for that particular seizure. Like in case it is GTCS, then we can prefer giving our patient which drug? Of course, the valproate. So in case it is GTCS, then my preference should be to give my patient a drug of choice for GTCS, that is valproate. Now tell me, in case it's a patient of focal seizure that you saw, right? It's a case of focal seizure this time, right? So this time my patient is getting a focal seizure. See, intranasal, intrarectal as compared to intramuscular as well as IV, of course. See, the route of administration of benzodiazepine is very clear. Ideally IV, followed by IM, and then comes your intrarectal and intranasal. Intranasal bioavailability has been a constant issue every time, right? Batao. Your patient is in focal seizure. That is known by another term, if you remember, as epilepsia partialis continua. Epilepsia partialis continua. It's a continuous seizure, which is a partial seizure, and it is an epileptic patient. Okay. So what is the ideal drug to be given? Tell me. सांग मला जो मला माहिती नाही. Tell me something which I don't know. बताओ. Lamotrigine is a preferred drug for focal, but is lamotrigine available IV? Apply your mind. Keep your senses open on this. Whenever you want to give it, you have to give it IV. Then you follow the Lokpal. Lamotrigine, oxcarbazepine, carbazepine, all three of them are oral. Got it? Now the next step will be phenytoin or levetiracetam. As compared to anyone around, at the moment, we generally prefer giving which one? Levetiracetam. Side effect of phenytoin is a big issue. Levetiracetam is always a safer drug. Shouldn't we give valproate for focal? For focal seizure, valproate is not in the first line. Okay. See, open your mind again, think about it, what I was speaking, carbazepine, oxcarbazepine, or even phenytoin. All three of them, if I know, are oral tablets. Okay. They're all oral tablets. Okay. Right. In case the patient is a drug defaulter, in case my patient is a drug defaulter who has not taken any drug, or who has taken the drug and stopped taking the drug suddenly, drug defaulter, then in that case, my opinion will be to restart the therapy. Got it? Okay. See, the ask anti-epileptic drug of choice for status, your answer should be drug of choice as per the seizure type. In case it's a drug defaulter, restart the therapy. That is the ideal thing. Got it? In case of refractory epilepsy, you know, we have done this so many times. Refractory, not responding to the standard anti-epileptics. One would be early refractory, and the next one will be a late refractory. Some of the authors have put the word late refractory now as super refractory. Chalega. Super se bhi upar, you know. For early refractory status, yes, we'll like to give midazolam infusion as a preferred regimen. And for late refractory or super refractory, which is now known as, yes, we like to give our patient thiopental. Okay. Drug of choice for status is always lorazepam. IV, if not excess available, intramuscular midazolam. Chalo, we all know this. Good. Next, move into the next one. The 68-year-old male patient has come with sudden violent flinging movement of the right arm and the leg. The word flinging comes into your mind. What comes into your mind first? Obviously, a ballismic movement on one side, right? Yeah, we have got a lacunar infarct, but where is the location of this lacunar infarct? Yes, it has to be in the subthalamic nucleus, so the STN, and that too the contralateral subthalamic nucleus that you believe. It's a very straightforward direct question, I believe. Absolutely no corollary on this. So we know globus pallidus, if there is a lesion, then which movement disorder is going to come in? Ethitosis, right? Great. Posterior limb of internal capsule, if there is a lesion, lacunar infarct, that would more often relate to what? Dense hemiparesis. While if there is a lesion in putamen, what are you thinking about? Not an infarct, but more of an intracerebral hemorrhage, which is of the type hypertension. Okay, the most common site for the hypertensive ICH is always a putamen. Okay, fine. Great. So that's an easy question. Which of the following statement regarding dementia of Lewy body is incorrect? Patient may show marked sensitivity to antipsychotic medication. If you know about DLB, we have been talking a lot about in the classroom teaching also. These are patients actually who have got a very marked sensitivity to antipsychotic medication. Why? See, they have got one problem, if you remember, visual hallucinations. Okay? And you give a drug to suppress a visual hallucination, that is possibly a dopaminergic antagonist. Got it? And the moment you give it, what flares up in the patient? The symptom of bradykinesia and rigidity. That is, all the symptoms of Parkinson are going to come back. So they have got a marked sensitivity to antipsychotic. Not only that. If I give my patient levodopa, that is a drug for treating Parkinson, what increases in the patient? Visual hallucination. So any kind of a dopaminergic agent or even an antipsychotic agent, they are highly sensitive to it. Sensitivity, I hope you know, they react to it very badly. Okay. Visual hallucination are the core clinical feature. Yes, I agree with this. Parkinson can develop concurrently or within an year of a cognitive decline. Yes, it's fine. Final statement, option D. But going with option B, yeah, memory impairment is the earliest and the most prominent feature. No, this is something not fully correct. It's not fully correct. Yeah. See, I'll tell you why. When you appear for an exam, right? Expected question: where is Taj Mahal located? Batao. Easy question. Delhi, Jaipur, Agra, Mumbai. Your answer is obviously Agra. Agra? No problem. But when you go to INI-CET, where is Taj Mahal located? Delhi, Jaipur, Mathura, Ahmedabad. Now Agra is missing. INI-CET is in a level up. Got it? So you might mark it as Mathura because Agra and Mathura are nearby. You might mark it at Jaipur because marble was built up in Rajasthan. Rajasthan capital is Jaipur. Some people say Delhi because you come to Agra via Delhi. Some people say now the better capital is Ahmedabad, the Gujarat model, so they will build up a replica over there, right? But when you go for NEET PG, who constructed Taj Mahal? Shahjahan, workers, या all of the above? Obviously, sir, all of the above. Okay. So sometimes, you have to be very careful in answering a question. You have to use your knowledge with the wisdom also. So memory impairment is not an earliest feature and most prominent. I disagree with it. Option D, I agree. Option C, I agree. Option A, of course, I agree. But option B, I'm not fully agreeing on it. Got my point? So memory impairment is the earliest and the most prominent feature. No, it comes early, I agree, but it's not a prominent feature. And it's not the earliest, please. What is the earliest symptom? The earliest symptom would be a visual hallucination in the patient with some symptoms of what? Bradykinesia. This would be the earliest symptom. Then as the stage progresses, you will go into a stage of dementia. Not the earliest, but early symptom, I agree with it. Okay. Right. Not the earliest, but still early. Okay. That's what I'm telling you. Read the question again. Have to mark these kind of questions with your wisdom, not knowledge all the time. You marked A considering B is correct. B is somewhere incorrect option. Not the earliest, but an early symptom and not a prominent symptom. What is a prominent symptom of dementia of Lewy body? One symptom that comes obviously earliest and prominent is always a visual hallucinations. Got my point? Okay. Chalo, that was a tough one. Let's go to the easy one and a common topic. 62-year-old right-handed male patient is brought to the emergency department after a stroke. He ignores people, objects on the left side, only eats the food on the right side of the plate. He's alert, oriented, unaware of his deficit. What is this? Kya hai ye? This is nothing but your hemispatial neglect. Hemispatial neglect. You neglect the half side? Yes. And which side is the patient neglecting exactly in this question? Yes, he is neglecting the left side. So, apna time aayega, I agree, but apna time apun khud laayega is the most important thing. Okay. Right. So, he neglects the left side. Where is the lesion likely in? right angular gyrus that is located in the inferior parietal lobe, and the right side is always non-dominant. Okay, now which arterial occlusion is going to cause this kind of a problem? Please tell me. Which arterial occlusion is going to cause this kind of a problem? Of course, the middle cerebral artery. Yes, the middle cerebral artery. But which division is it? Yes, it's always an inferior division. Okay. So that's a very commonly asked question, simple question. Now let's read this one. Which of the following statement about anomic aphasia is incorrect? Patient often uses circumlocution to describe objects they cannot name. Is it true or false? Yeah, it's absolutely true. Circumlocution is something that they do perfectly. If I ask them this, what is this? They will tell me it's a useful object required for writing on a piece of paper. But what is the name for this? They really don't know. They are beating round the bush circumlocution. Okay. Comprehension and repetition are typically preserved. Yes, naming is the only deficit occurring in a patient with anomic aphasia. Lesion often involves the angular gyrus of the inferior temporal region. Yes, also absolutely correct. Speech is non-fluent, poor grammar, frequent paraphasia. I'll not agree with D completely. Paraphasia is incorrect naming. That might happen. But not speech is not non-fluent. No, it's fluent. Okay. So that's a simple, straightforward topic, anomic aphasia. And don't forget, it's the most common aphasia of all the types that we come across with. It's the most common aphasia. Right. Right. 64-year-old right-handed woman presents with sudden onset fluent speech filled with paraphasia. So at the moment her fluency seems to be quite normal with some paraphasic errors. Okay. That is some problem somewhere in naming, I believe. So naming is all right, but maybe an incorrect name given to the object. Okay. She's got a poor comprehension. Her understanding is very poor, almost gone. But intact motor strength. Look at her. Her motor movement is totally normal. Now, which of the following artery is involved? Looking at this topic, maybe, yeah, you hit the right chord. This time that we are thinking about which aphasia? Yes, we are thinking about a patient of Wernicke's aphasia, which happens due to lesion in the inferior division of the middle cerebral artery. So MCA and FARC, don't forget, these are quick topics often asked in any kind of exam that you appear in. So this is the middle cerebral artery, MCA. This we have a superior division, and this one is a inferior division of the MCA. Superior division of the MCA supplies which lobe of the brain? Frontal. Inferior division supplies which lobe of the brain? Temporal. So which aphasia we're going to have in the lesion is in the superior division? Broca's. And this one? Wernicke's. Well, if the proximal part of the MC, the M1 part is involved, then everything is gone. We end up having which aphasia? A global aphasia. Right? And of course, if the inferior division is involved, Wernicke's aphasia would be seen. Yes. Motor paralysis won't be seen because the frontal lobe is totally spared. Okay. Right. We all know this. 68-year-old male patient comes to the ED emergency department with right-sided weakness, slurred speech for the last 2 hours. CT scan shows no hemorrhage. His blood pressure is 185 by 105. INR is 1.1. Okay. Which of the following is the next appropriate step? Should I administer altiplase immediately because the patient has come within the window period of thrombolysis? Should I start an aspirin therapy, monitor for the neurological worsening? Should I lower the BP below this before giving thrombolysis? or should I defer the thrombolysis because it's an old patient? Yeah, this question might make you sense over option C. Yeah. So option C is the best option, right? And we have to lower the BP below this. At least the systolic should be below 185, because it will increase the tendency of hemorrhagic transformation. Okay, it's a contraindication. If not thrombolysis, okay, if not thrombolysis, then what should we do? Okay, I'll give you some simple reasons what should be done next. Okay, tell me. Patient comes in the hospital with right hemiplegia, with the global aphasia, and we have a duration of almost 1 hour for these kind of symptoms. In the patient, the NCCT brain that we have done is absolutely within normal limit. There's no problem with it, right? What should be done next? Tell me. What is next step that you like to take? Yeah, we are in a large vessel occlusion at the moment, because global aphasia means M1 occlusion. M1 occlusion means the IV thrombolysis will not reach completely as a drug over there. So it's better if I put the drug into the thrombus and dissolve it by mechanical thrombectomy. But should it be done or not is a decision that I have to take. Yes. So I have to advise for what? Cerebral angiography first. I have to advise for a cerebral angiography for the patient. And in that case, what I need to do? If the large vessel occlusion is a problem, has been documented in our patient, I have to give the drug through the intra-arterial route. So intra-arterial recombinant TPA has to be given to the patient. Correct. Right. Now I'll tell you another scenario. This time a patient came with hemiparesis, with the power of somewhere 2/5. That's why I call it as paresis, with Broca's aphasia. That connects the dots. No, we are in the superior division, okay, with the motor cortex involvement, and we have given a patient IV recombinant TPA because he came in the first 1 hour of onset, again the same duration. Okay, and we find that after thrombolysis, the power in the limb is still 2/5. It hasn't improved a lot. Okay, what should I do next? Tell me. In this kind of a scenario, what should be done next? I'll repeat the question. Patient came with hemiparesis, power of 2/5 with Broca's aphasia. We've given a recombinant TPA IV because there was no contraindication as such. It's obviously an indication to give it. And the power is still 2/5. That means the deficit is still there. Tell me, if my patient has got Broca's aphasia, is it a large vessel occlusion or a superior division occlusion? Obviously a superior division occlusion. Dekho. Theory is something that you learn, but practical is something that you earn with your own wisdom. In the sense that you work in the ward, you come to know. What is the next possible thing? Every time you cannot go for an angiography. First of all, in this patient, are we suspecting a large vessel occlusion on the basis of Broca's aphasia? No, it's a superior division occlusion. Okay, yes, superior division occlusion. Ideally, I should go in for a diffusion weighted MRI first. What am I going to look for? I'm going to search out for what? Ischemic penumbra in the patient. Ischemic penumbra is still there and it's at large. In the sense, it's a very big ischemic penumbra that you have seen. Now in that case, it's better you give the drug into the artery. Yes, that is recombinant TPA into the artery, intraarterial. Got my point? So you have to give your patient IV. If no improvement, go for a diffusion weighted MRI. If there is an ischemic penumbra zone seen, then it's always better that you give the drug into the artery now. Because the ischemic penumbra is a zone which is not infarct, it's ischemia. Ischemia is something which I believe is salvageable, to a larger extent fully reversible. And because of this ischemic injury, that is ischemic penumbra that you see, we are actually having in our patient what? A deficit. Got my point? Right. Why diffusion weighted MRI? Why not cerebral angiography? I'll tell you. Because at the moment, you are not suspecting a large vessel occlusion. Understand the concept of large vessel. M1 is a large vessel. The M2 division are relatively small vessels. In them, what happens is there is always a small occlusion there. Okay, but surrounding area suffers a larger damage due to ischemic injury. And IV thrombolysis is not all the time reaching it everywhere. So it's always better to go for a diffusion weighted MRI and then proceed. I'll tell you one more practical problem, wisdom. Cerebral angiography, who is going to do? A interventional neuroradiologist, an intraarterial thrombectomy, again that. So that kind of a structured maybe investigative modality and treatment is not everywhere available. So we have to go in a specific way like this. If there is no penumbra, wait and watch. God will help. Chalo, now answer this one. Which of the following statement regarding subarachnoid hemorrhage is incorrect? Incorrect, we are asking. Thunderclap headache is a classical presenting symptom. Yeah. Non-contrast MRI is the initial investigation of choice. No. This even you know and I know, it's always an NCCT brain. Okay. Xanthochromia and CSF can confirm SCH if CT is inconclusive. Or nimodipine is used to prevent delayed cerebral ischemia. Yes. Chalega, that's fine. Nimodipine is a drug which is an intracerebral vasodilator because it inhibits vasospasm. And vasospasm will cause a further on disability in the patient because of ischemia and infarction in patients of SH. Xanthochromia and CSF can confirm SH if CT is inconclusive. Is it true or false? Tell me that. Arey, answer is B. Yeah. You and I know it's incorrect. But option C, tell me. Yeah, it's correct. Unfortunately correct, although still in the book, not practically followed. Okay. So this time when you take out the CSF, keep it in the test tube, you will find that there is something which is red or maybe yellow in color like this. And it is same throughout in all the 3 test tubes. Okay. Right. Okay. All right. Now comes Zahir Wali Kheer, the Hira Thakur with his Brown-Séquard syndrome. The legend is back. 35-year-old male patient presents after a stab injury in the right side of the thoracic spine. On examination, he has got loss of power and motor function and proprioception on the right side of the body. Okay. So on the right side, I believe in my patient, there is involvement of what? The motor, that is weakness, with the involvement of which segment? the posterior column also. And loss of pain and temperature on the left side below the lesion, right? So spinothalamic could be involved on this side. Okay, below the label. So which of the following best explains this kind of a damage? Yes, it's a hemisection on the right side of the spinal cord at the level of the injury. Correct answer is D. So we've done this topic so many times. We all know this, we all remember it. And don't forget Hira Thakur, Zehar wali kheer. And people who don't know who is Hira Thakur and what is Zehar wali kheer can watch Star Gold tonight. There. Chalo, next question. Which of the following statement about Myasthenia gravis is incorrect? Incorrect. We'll start with option D. Pistol. Ptosis and diplopia are common presenting feature. Yes, of course, because ocular muscles are most often moving, and any muscle that moves more, exerts more, will get weakness more often. Okay. Symptom typically worsen with exertion, improve with rest. No doubt on this. It's absolute correct statement. It is commonly associated with thymic abnormalities. Of course, yes. More often hyperplasia than thymoma, but thymic abnormality happens. Yeah, dependent reflexes are typically diminished during myasthenic crisis. Nah. DTR even in the crisis phase will remain normal. In crisis, what would be the error? Respiratory muscle weakness. So respiratory muscle weakness, which is often precipitated by an infection, would be one thing that would happen in the patient more often. And ideally, what is the treatment of choice for them? In a case of a crisis, you need a Sanjeevani, that could be intravenous immunoglobulin or even a plasmapheresis. Got it? Okay. 28-year-old female patient presents with recurrent episodes of unilateral throbbing headache associated with photophobia and nausea, lasting for several hours. She experienced visual zigzag lines before the headache came in. Which of the following is a likely diagnosis in her case? A unilateral throbbing headache in a female patient. Female patient with a throbbing headache, which is unilateral with nausea and photophobia, is a classical summary for migraine, right? Now she has got zigzag lines before the headache comes in. That is a fortification spectra that we saw. That basically is a part of aura. And what kind of migraine is it? Yes, it is known as a classical migraine. Tension type headache will come with a band-like sensation. Cluster headache more often in male, explosive retroorbital pain. Occipital lobe seizure will have visual hallucinations only. Okay. So how do we classify migraine? We all know. The classification of migraine is clear. Migration classification is basically based on a phenomenon known as aura. If in case in my patient aura is present, or in case in my patient the aura is absent. Aura is present is classical migraine. Aura is absent is not known as unclassical or western, it is known as common. The word common comes with the belief because 80% of patients of migraine don't have aura. That's why common, 20% are classical. Just a quick recap on this also. Asymphalgic migraine. Asymphalgic migraine. What is this? Read the name again. A absent, symphalgic. Algic means pain. Symph means head. Yes. So this time the patient of migraine just has got aura, but doesn't seem to have what? Headache. Headache. So headache is absent, aura is present, and it's very difficult to diagnose these people because they mimic occipital lobe seizure also to a larger extent. Okay. Asymphalgic migraine comes with just aura, with no headache. Okay. Right. So a quick recap on visual hallucination, because this is something commonly asked in the exam. Because you're preparing for NEET PG, I agree. Yes. But by the time NEET exam gets over and the result comes, ionized CT will come. If provided the NEET PG happens on time. I'm not making fun, but my past experience tells me a different story every time. because whenever I see a NEET PG date sheet, I think court case. Next thing I think postponement. Now the question comes, when is the exam going to get postponed? It has already got postponed, I think, so it will happen on time this time. Chalo. In case the visual hallucinations are formed, that means a complete image is seen by the patient, or it is just a hazy visual hallucination. What are your differentials? Formed visual hallucination, yes, is a classical picture of temporal lobe epilepsy. Temporal lobe epilepsy. Temporal lobe epilepsy. Hazy means occipital lesion. So in temporal lobe epilepsy, you have formed visual hallucination every time. Okay. Right. Some comments on NICET and NEET. That's what I tell about students. Prepare for NICET. Only exam that happens on time with no court cases, no postponement. I remember in COVID also once, it was second wave going on, they conducted NICET. Ho ke rahega. Student went in PP kit to give exam. Chalo. Right. Okay. 42-year-old male patient presents with low-grade fever, headache, altered sensorium. CSF reveals lymphocytic pleocytosis, elevated protein, low glucose. Which of the following is the most appropriate next step in management? Yeah, LP we have done. Maybe if I remove this part, I don't know. Why did I got it printed? If I remove the CSF analysis part from this, tell me. What should have been done first in the patient? Yeah. Always remember, my patient has something which is related to a raised ICT like papilledema. You have to rule out a space occupying lesion in the patient. So is my patient passing or failing? I hope you remember fails. In case your patient has focal neurological deficit, please go in for neuroimaging, because a space occupying lesion often can create these kind of meningismus trouble. In case your patient has got altered sensorium, which could be a sign and a symptom of raised ICT again. In case your patient is found to be immunocompromised, please think about this, because space occupying lesion in immunocompromised patient could be a toxoplasmosis. In case your patient already has a lesion in the brain, think about a space occupying lesion again. And above all, if the patient has got seizure, yes, you have to go for neuroimaging first and then proceed for LP, because in case you have a space occupying lesion, what will happen? If you miss it, yes, you will take out the CSF will come out, space occupying lesion will come down and patient will go away. Okay. So you just remember this acronym of FAILS, right? Right. Chronic alcoholic is brought with confusion, horizontal nystagmus and a white base gait. Okay, so we are having a triad of what? Goa, right? Goa. Capital of Punjab, Goa. No, capital of Punjab is Chandigarh. Capital of Haryana is also Chandigarh, but we Punjabis don't want to share things, so we'll make capital as Goa, because English is a spoken language in Goa before 8 p.m. but in Delhi and Punjab after 8 p.m. Simple. Okay. What are you going to do incorrect? Batao. Yeah, thymine deficiency impairs the glucose metabolism, leading on to neurotoxicity or lactic acidosis. Yes. Okay, MRI will show thalamic hyperintensities. Agreed on this. Hypomagnesemia may blunt the response to thymine therapy. This is something new. We have seen that magnesium is also kind of a cofactor for a proper working of thymine to work. Although thymine itself is a cofactor for the enzyme in the Krebs cycle, but magnesium is also one of them. So if you give magnesium, it really helps. It helps you to improve in the thymine therapy. Okay. So IV dextrose should be started immediately to reverse energy deficiency? No. If you give dextrose, it will accumulate more, new neurotoxicity would happen. Okay, right. Right, fine. Going to the endocrine, quick recap on the endocrine also. 30-year-old women presents with amenorrhea and galactorrhea for the last 6 months. Our prolactin is markedly raised at 240 MRI, reveals a 1.2 centimeter pituitary lesion. We are having a macroadenoma, and 1.2 centimeter is how many millimeters? 1.2 centimeter is how many millimeters? Bolo. I know your maths is poor. That's why you are here on a Saturday night with me. On a cyber up, you would be chilling out somewhere or Whitefield. Yeah, 1 centimeter is equal to 10 millimeter. So it becomes almost 12 millimeters. So you are having a macroadenoma at the moment. Okay, very good. Maths is good. Not that bad. Sorry. So which of the following is the most appropriate first line treatment? Always remember, first line treatment has to be medical, and cabergoline is always a preferred therapy. Not a TSR in a macroadenoma even. First treatment of choice is always medical. Okay. 15. 45-year-old male patient presents with coarsening of facial features, enlarged hand, excessive sweating, IGF-1 elevated, 75 gram oral glucose, growth hormone suppression test with the nadir of this and that. So it's basically a case of acromegaly. What are you going to do next for acromegaly patient? Tell me. Start somatostatin analog therapy immediately. Repeat the IGF-1. Refer for transsphenoidal surgery without further imaging. Wow. Obtain contrast MRI of the pituitary. Common sense. First, the pituitary MRI. If you find a tumor, yes, approachable, you operate by transsphenoidal resection. In case the tumor is not approachable, then you can go even for a radiotherapy or medical line of treatment. Okay. We would like to follow the protocol here. Yeah, if it is given D, I'll change it. It should be B. Because MRI is the first thing of the pituitary that we need to differ out. Is the tumor surgically approachable or inoperable? Sometimes, you know, we are going to see somatotrophic adenomas. We often see somatotrophic adenomas. Okay, we often see somatotrophic adenomas with a invasion into cavernous sinus. Cavernous sinus is a zone in which the somatotrophic adenoma has approached. So in these kind of patients, you know, it's very difficult to operate upon, because if you operate and remove the transsphenoidal resection, you might remove the cavernous sinus along with it. So in that case, you have to go in for what? Radiotherapy first. So always the MRI is the first choice, and then after that you locate where is the tumor exact location, and then yeah, medical line of therapy in acromegaly comes when there is no remission on surgery. Surgery is ideally the treatment of choice. No doubt on this. Okay. Okay. So answer should be B. I don't know why it's again D. Chalo. It's not the final exam. Final exam is on which August? Just when is the final NEET PG exam? What date is it? Kajani's. Read the question and tell me the answer. Okay. 40-year-old male patient presents with excessive thirst, urination. His serum sodium is 150. Serum osmolarity is 305. Urine osmolarity is low at 120. After administration of desmopressin, it increases to 450. Yes. What is incorrect regarding the diabetes insipidus in this patient? What kind of diabetes insipidus is it? Yeah, क्या बात है? 3rd August. क्या बात है? Before 15th August, 3rd August. Just like 2nd October, 3rd October, 3rd August. You'll go to Goa. Panjin. Yeah. Okay. चलो. ये दुख खत्म ही नहीं हो रहा यार. एग्जाम ही नहीं हो रहा. Central DI is characterized by deficiency of ADH. Yes. Nephrogenic DI has minimal or no response to desmopressin is also correct. Desmopressin challenge test differentiates the central from nephrogenic DI is absolutely correct. Complete central DI typically shows no change in urine osmolarity. That's absolutely incorrect. Okay, so this is a classical easy question, right? The answer is D. Right. If we are asking you incorrect, why are you answering me B? Should be D, no? Nephrogenic minimal or no response to desmopressin? Yes. Why is everyone answering me B? Okay. 68-year-old male with a small cell lung carcinoma presents with confusion and lethargy. Sodium is 114. The serum osmolarity is 260 on the lower side. Urinary sodium is above 20. That's natriuresis, with urine osmolarity being slightly on the higher side. Is euvolemic? Which of the following is most consistent with SIADH? Yes. Tell me. Consistent with SIADH. Inappropriately concentrated. Tell me. In SIADH, do you have hypernatremia? No. You already have hyponatremia in the patient due to a dilution effect. With a dilute urine, no. We generally have a concentrated urine in the patient, because all the water goes from the urine into the body. So that's not correct. Low urinary sodium with a high serum osmolarity. No, ulta. You always have high urinary sodium, okay, with a low serum osmolarity. Yes. Inappropriately concentrated urine despite hyponatremia. Yeah, it's actually a kind of a concentrated urine despite hyponatremia. Yes. Hypovolemia with orthostatic hypotension, no, it's more of a hypervolemic change initially and then it becomes euvolemic. Okay, so is there any confusion on this question? Ignore the part that we have tried to explain how does SIADH come in biochemically, but just look at this. Which of the following is most consistent with SIADH? Okay. Right. 36-year-old woman has a weight gain, facial rounding, purple stye, proximal muscle weakness, 1 milligram overnight DEXA suppression test fails to suppress the serum cortisol. That is a DEXA challenge test. Plasma ACTH is on the lower side. What is your likely diagnosis? Simple. Tell me. Orthostatic hypotension and all doesn't happen here. First of all, low GVP also doesn't. He's euvolemic. Why will they be ortho? So we are asking what is correct in this. Consistent, not incorrect. What is the answer for this one? Easy question, na yaar. Ye to isme, if there was an ectopic ACTH secretion by a bronchial carcinoid even, or a Cushing disease due to a pituitary ACTH adenoma, in both the situation the patient's ACTH would have been high. So it's an adrenal adenoma producing cortisol. A. Now tell me why not D? D is also same now. Cortisol goes up, ACTH comes down there. But for D, I believe you have to have a history. Already in the question, there will be a history of steroid use or abuse. Okay, so Say clearly. Okay. 25-year-old type 1 diabetic patient presents with abdominal pain, vomiting, rapid breathing. Lab shows a pH of 7.12, bicarb of 10, and glucose of 480, serum ketones positive. Which of the following regarding the management of decay is found to be incorrect? Initial fluid resuscitation should be started with an isotonic saline. Yes, 0.9% saline is ideal therapy for the patient. 0.9% saline. Yes, isotonic saline. Correct. Insulin infusion should be started after initial volume resuscitation. That's agreed because the regimen is always flip. Fluid, insulin, and then potassium. Potassium should be monitored closely and replaced even if the serum levels are initially normal. Yes, because initially they are normal and then it will dip down because of the insulin therapy. Okay. So what are we left with? Bicarb is recommended routinely when the pH is below 7.3. No. Bicarb is recommended only when the pH is below 6.9. Only then, not always. So got my point. So bicarb therapy is to be given only when the pH is below 6.9 or even 7. Not all the time. Okay. So that's simple, easy question. Now the last question. 32-year-old woman presents with fatigue, food intolerance, weight gain. TSH is 22, free T4 is below normal. She started on levothyroxine. Which of the following is the most appropriate approach to management? Start combination of T3 and T4 for the faster symptom relief. Start high dose levothyroxine. Repeat thyroid function test after 3 days. Start a low or moderate dose levothyroxine and recheck TSH after 6 to 8 weeks. What is your ideal therapy? Yes, we got it right because nothing suits us better than option D, I believe. High dose levothyroxine is not to be given, not to normalize quickly. Kyun? Why? Levothyroxine is T4. If I give it to the patient, then suddenly T3 conversion and it will affect the heart of the patient. And there could be a cardiac or CNS kind of problems. So never go for a high dose levothyroxine in the patient. Right. Repeat thyroid function test after 3 days doesn't make any sense. It's not going to change. Okay. So answer my question this. I've got some doubts. I've been discussing this thyroid function and all. A lot of people in patients OPDs also. If I want to get a thyroid function test done or the TFT done for the patient, should it be done empty stomach versus anytime? Tell me. I think so in one of the batch I've already discussed this concept. So tell me this one first. If I want to get a thyroid function test done for any patient, should I advise it empty stomach fasting or anytime? Because I've seen lab people, they always tell me empty stomach fasting ana, khali pet ana. Tell me, TFT thyroid function test. Empty stomach. anytime empty stomach. सब सुनते हैं इधर उधर empty stomach. बिल्कुल. Sudhanshu Shukla is giving us congratulations from the International Space Station कि we are getting every test empty stomach. क्या बात है, सब खाली पेट है. Anytime. I'll tell you a reason why, because some misconceptions are at our end are so blunt that we do not want to change it even. Because you are giving T4. T4 has got a half-life of 7 to 10 days or even 14 days. A tablet taken a day before or even a day before that is going to be there in the patient. So that will reflect a normal kind of a thing. So it's not like, fasting will help you to have a catch of hypothyroid more than anyone else. So any time of the day is fine. Okay. Yeah. And tell me, if you are getting it any time, and should be done on tablet or off tablet? Well, some people I've seen, the crazy people, what they will do, they will stop the tablet a day prior or a day before, or even the same day, and then they will check कि बिना गोली के कैसा रहता है टेस्ट. Smart people, no? So empty stomach का actually scam है. I'll not discuss it on the YouTube channel because people will sue me for that. Why an empty stomach is done all the time. See, I'll tell you. Even you forgot to take the tablet and got the test done doesn't really matter. Taking a tablet will just change the value by 10%, not more than that. Okay, so don't worry. Anytime on tablet is better than off tablet. So tell your patient not to stop the medication, take it. On tablet is always better than off tablet. Okay. Right. So I advise my patient to get what test done. So in the thyroid function test for follow-up, what are the 2 tests done to be done? Tell me, out of them. Should I get a TSH FT4 or should I get a TSH FT3 done for the patient? Or even FT4 if free T3 also? Tell me. Which of the 2 tests should be done in follow-up? TSH FT4 or TSH FT3? %90 of you get everything done. Package mein kara le. You're giving T4, you have to get the patient T4 done. Always better TSH and free T4. So I advise my patient to get a TSH free T4 done. He went to the lab, started fighting that I'll only pay for TSH because T4 wala test is free. Wow. Typical Delhi ka aam aadmi. Everything they want free. He came back home and WhatsApp me, sir, what about T1 and T2? वो नहीं कराना. मैंने कहा उसके लिए टिकट बुक करो. एयरपोर्ट टर्मिनल है दिल्ली के T1 T2. फ्लाइट पकड़ो और पहुंच जाओ स्पेस में अब सीधा. वही जगह है तुम्हारी. चलो. So on this note, तो पीजी एस्पिरेंट देखकर फ्लावर समझे क्या? नहीं, डेमजोनियन है, फ्लावर नहीं, फायर है मैं. So most important, when you go for NEET, don't forget what? Your basics. Okay? Chalo. Okay, good night and all the best for the exam which is going to come. Okay. Right. Thank you. No. Increased dose of levothyroxine should be done immediately when you see the report. TSH is on the higher side and the dose should not be doubled or something. Okay. Chalo. Bye. Good night. 3rd August. 2nd August. 3rd August. All the best. Okay. Chalo. Thank you.